All right, hello everyone. So today I'm going to be presenting the final project presentation for the class, and I am a little biased uh, regarding the disease I'm about to present because I am a medical assistant at a dermatology clinic. But I just find it so fascinating that I couldn't pass up the chance to talk about it. And it's melanoma, which is the deadliest type of skin cancer that a person can have. So melanoma develops in the cells that produce melanin or melanocytes that provide the pigment that gives your skin its color. It occurs after DNA mutation due to high exposure to ultraviolet radiation from the sun, or even tanning beds in salons. An example of this is BRAF, which is an oncogene that is often altered in melanomas. And the most common mutation you would see in this gene is uh, it leads to what's called the PV600E protein substitution. Um, in the United States, currently, it's the fifth most common cancer in men and seventh most common in women. Uh, and about 50,000 cases are diagnosed annually. Usually, 15 of these cases lead to death, and that is only due to like negligence, not having your annual skin checks, and just not even using sunscreen or just exposing yourself too long in the sun. The etiological causes for melanoma include family history, in which there's a 5 to 10% chance in patients, and even a 2.2-fold higher risk when someone has at least one affected relative. Having blue eyes, fair hair, pale complexion, pretty much saying that one that has an easy skin reaction to sunlight or is easily burned. Someone who freckles a lot, having excessive benign or dysplastic looking melanocytic nevi. So size in this case doesn't even matter. It's really only the population number, and if one is in an immunosuppressive state as well. In addition, like stated before, if someone has had a lifetime of sun exposure, which can lead to the formation of pyrimidine dimers or deamination of cytosine into thymidine, and if they live at a low altitude, as in like close to the equator where the sun is the most strongest. Now, to diagnose melanoma, uh, you would have a clinician or dermatologist assess the lesion with an unaided eye, or with the aid of a dermatoscope, which is just an instrument that can provide like a magnified view of the lesion. They usually go by the ABCDE rule: A for asymmetry, B for irregular border, C for color variation, D for diameter, anything greater than like 6 millimeters, and E for elevated surface. And the most common syndrome that melanoma usually falls under is the FAMMM syndrome, also known as the familial atypical multiple mole melanoma syndrome, which is an autosomal dominant genodermatosis that is really comprised of multiple melanocytic nevi, usually more than 50. And the person also does have a history of melanoma in the family, which doesn't help in the case. Um, and the CDKN2A gene is the one that gets mutated in this situation and has even showed links to increased risk for development of pancreatic cancer and other malignancies. The clinical manifestations that are associated with melanoma are like new lesions, bumps, marks, or moles on the skin that have been present for a short period of time, that have changed in size, shape, or color, sores that don't heal, the spread of pigment from the border of a spot into the surrounding skin, redness or swelling beyond the border of the mole, itchiness, tenderness, or pain in the spot, or change in the surface of the mole like scaling, oozing, or bleeding, or something like that. For metastatic melanoma that is spread from the skin to other parts of the body, the patient can experience swollen or painful lymph nodes, um, which is not uncommon in multiple cancers, headaches or seizures, fractures or bone pain, loss of appetite, unexplained weight loss, or hepatomegaly or increased size of the liver, difficulty breathing, or even a persistent cough. Now, this implies that melanoma can spread to more systemic areas other than the skin, which we originally know. Um, melanoma does have the ability to develop in or near a previously existing precursor lesion, or in any segment of healthy looking skin. It can even appear on other parts of the body that are not exposed to the sun, such as like palms, soles, and even the perineum. Examples of lesions that are precursor lesions of melanoma are like common acquired nevi, dysplastic nevi, congenital nevi, and cellular blue nevi. A melanoma will have two growth phases. So one is the radial phase, where it will grow in a radial fashion in the epidermis, and over time can then grow to the second phase, which is the vertical phase, where the cells invade the dermis and can metastasize. It most commonly metastasizes to the skin and lungs, but can sometimes metastasize to the small bowel. We can have four types of melanoma. One is superficial spreading melanoma that comprises about 70% of melanomas and is usually flat, but can become irregular and elevated later on, and will average around like 2 centimeters in diameter. The second one is nodular melanoma, which is about 15 to 30% of the melanoma cases and are usually blue-black, but can lack pigment in some occurrences. The third is lentigo maligna melanoma, which is about 4 to 10% of melanomas and are usually larger than 4 centimeters. They're usually like flat, tan, with about like notched borders. And the last is acrolentiginous melanomas, which comprise about 2 to 8% of melanomas in white people, and about 35 to 60% in dark-skinned people. Now, these can appear on the palms and soles as like flat, tan, or brownish stains with irregular borders. Now, the most important diagnostic test we would use to diagnose someone with melanoma is a skin biopsy, whether that be like a shave biopsy where they kind of shave off the top layer of the skin. But this is usually done when melanoma is not as suspected since the sample may not be thick enough to measure how deep the melanoma has invaded the skin. Or we can even use a punch biopsy, which is depending on how deep they want to remove for the pathologist to review. And then it'll be sent off to the dermatopathologist lab. They will then examine certain features such as the tumor thickness and the mitotic rate, which can help indicate the stage of melanoma, if it is melanoma. A differential diagnosis that can accompany melanoma is an epithelioid or Spitz tumor, which is an uncommon, really benign, honestly, melanocytic nevus that is usually acquired and has the same histological features as melanoma. It's usually defined as a symmetric, well circumscribed, smooth or warty kind of firm dome-shaped nodule that can be less than 1 centimeter. Usually it appears by itself, but it can also appear in clusters. They're also very uniform in color. And like I said, they are similar to melanoma, but they were studied by researchers to not have the same malignant behavior, which differentiates them from melanoma. And complications with melanoma, there can be complications if treatment or diagnosis, even of the melanoma, is delayed. It includes like secondary infections, since the melanoma has already begun to invade sensitive areas of the normal skin barrier, scarring, lymphedema, local recurrence, especially if the melanoma is more advanced than it was at the time of diagnosis, metastases, and even depression and anxiety due to the possible aesthetic look of the melanoma lesion. And that's about it. So hopefully everyone's doing well in the class, and good luck on the final.